A 36-year-old woman is evaluated for abdominal distension and absence of bowel movements for the past 3 days. She underwent an emergent laparotomy for acute cholecystitis 4 days ago. Her temperature is 37.5 degrees Celsius, 99.5 degrees Fahrenheit. Blood pressure is 118/72 millimeters mercury, and pulse is 84 per minute. Abdominal examination reveals a mildly distended abdomen with diffuse tenderness to palpation. Bowel sounds are hypoactive. Which of the following is most likely explanation for this patient's condition? Choice A, adhesions. Choice B, volvulus. Choice C, intussusception. Choice D, ileus. Or choice E, sepsis. I'll wait 5 seconds and answer the question. This patient had a recent stressor, in this case surgery, and now he has hypoactive bowel sounds and he can't pass gas and he can't pass stools. So this is most likely due to impaired peristalsis, also known as a paralytic ileus. Choice D is the correct answer. USMLE, if they want to test you on ileus, they'll usually give you this very classic presentation of a patient has surgery and now he has hypoactive bowel. There's plenty of other stressors that can cause ileus, such as sepsis or electrolyte imbalances, diabetes. But typically, it's a diagnosis of exclusion in those cases because those things can cause all kinds of different problems. So with that in mind, let's take a look at some of these other answer choices. Choice A, adhesions. Fibrous adhesions are a risk for patients who had a prior major surgery in the abdomen. The inflammation caused by the surgery will lead to fibrin deposition, and then years later, the fibrous adhesions can potentially cause a bowel obstruction. Now, in USMLE questions, if they want to talk about bowel obstructions, they'll usually give you a very buzzy descriptor of air fluid levels. Also, a notable difference in adhesions versus this vignette is that in adhesion, you would have hyperactive or high-pitched bowel sounds. Anyway, yes, this patient just had a surgery, but adhesions occurs years later. Typically, they wouldn't appear immediately like this, so it's the wrong answer. Choice B, volvulus. Volvulus occurs when a section of GI tract twists around itself. So the ones that you will hear about the most are midgut volvulus and maybe sigmoid volvulus. Midgut volvulus is mainly a pediatric diagnosis, and it occurs as a result of errors in gut rotation during development. I'm not going to go into the details of it. They usually don't ask you the specifics of that. But anyway, midgut volvulus can present with bilious vomiting. And if they mention upper GI series, that's usually very specific to midgut volvulus, because the upper GI series is mainly used to visualize the shape of the GI tract. And in midgut volvulus, because there is a malrotation of the gut, you're going to see what's called the corkscrew sign, because in a malrotated gut, it's basically all going to be on the right side of the body instead of the left side, and it's going to be spiraling downwards, and it looks like a corkscrew. The other type of volvulus you hear a lot about on USMLE is sigmoid volvulus. This is the opposite age range. This is mostly in elderly patients where chronic constipation overloads the sigmoid colon with feces and then it ends up twisting around itself. And oftentimes they'll give you the radiological finding, which is very buzzy. It's called the coffee bean sign. So you have this huge distended sigmoid colon, and it looks like a huge coffee bean, thus the name. Not much else to say there. There are other manifestations of volvulus, such as cecal volvulus, which occurs mainly in young adults. But for the most part, USMLE is going to be testing on either midgut volvulus in children or sigmoid volvulus in the elderly. Choice C, intussusception. This is mostly found in pediatrics, and this is where the bowel basically telescopes into itself. It can be found in adults, but usually there's an underlying problem that leads to it. So for pediatrics, usually how this will be described is that it'll be intermittent abdominal pain, and it will be relieved by the patient either flexing their knees or they'll be squatting down. And it can also present with bilious vomiting and quote-unquote current jelly stools, but they usually don't give that latter one, I think, because it's too buzzy. Choice E, sepsis. This is kind of a distractor. I mean, sepsis can also cause ileus, but of course this patient doesn't qualify for sepsis. She doesn't fit the SIRS criteria, which is 2 or more of either 38 degrees Celsius or less than 36 degrees Celsius, pulse more than 90, respiratory rate more than 20, or PaCO2 less than 32, or leukocytes are either less than 4,000, more than 12,000, or has 10% bands. If you have 2 of those, then you qualify as SIRS, and then you have to have an infection on top, and that'll be sepsis. Like I said, it's a distractor here. You have no reason to think this patient has sepsis. I mean, yes, she's post-op, and that's a risk for sepsis, but she, like I said, she doesn't fit the criteria, and ileus is a better answer. So just bringing it back, if you have a patient that undergoes surgery, or they have some kind of massive stressor and then they can't pass gas or pass stools, that's called paralytic ileus. I hope you found this video helpful, and I'll see you in the next one.